Good afternoon, everyone. Thank you so much for joining. We'll be starting in about a minute or so.
Great. Should we get started?
All right. Good afternoon, everyone, and welcome to our inaugural AJOG MFM Pink Journal Club. We are so thrilled to be bringing together our readers of AJOG MFM from around the world to discuss a recently published article. My name is Beverly C., and I'm currently a second-year maternal fetal medicine fellow at the University of Connecticut.
And I'm Michelle Wang, a second-year MFM genetics fellow at Beth Israel Deaconess Medical Center.
And I'm Mariam Ayash. I'm a second-year fellow at Columbia University. Together, we're the AJOG MFM editorial fellows for this year. We're very excited to be hosting our first AJOG MFM Journal Club with you all today. To start off, and to give you a little bit of background about the Pink Journal Editorial Fellowship Program, Dr. Adam Lukowitz, who's a maternal fetal medicine attending at Brown and is also one of our editorial fellowship mentors, will share a few words.
Hi, thanks so much for joining us today. This is our first inaugural AJOG MFM Virtual Journal Club. And so before we got started, I wanted to provide a brief overview of what Bev, Michelle, and Miriam are, which are AJOG MFM Editorial Fellows. So every year, second-year MFM Fellows from across the country submit their application for this program to the Society for Maternal Fetal Medicine's Fellowship Affairs Committee. The committee reviews all de-identified applications and provides us at AJOG MFM with the 3 or more applicants that they have selected to be editorial fellows for the upcoming year. The goal of the editorial fellowship is to provide insight into what happens to each manuscript from the moment it gets submitted until the final editorial decision is made. Each editorial fellow is assigned at least one deputy editor mentor who meets monthly with each fellow and tailors their experiences to their specific interests. And part of the editorial fellowship is that each class comes up with a project. Last year, the fellows created a special edition of AJOG MFM focusing on clinical debates, and this year, this esteemed group of fellows created the first ever Pink Journal Club.
All right. Thank you, Adam. We are so proud to be introducing the Pink Journal Club, affectionately now known as the PJC, to help readers critically review and understand research studies. So as a part of this Pink Journal Club series, we have a couple resources that we wanted to introduce to folks before we got started today. So first, we have just, on the website was the first slide for where to find information about us. There's a link under Connect that goes to the PJC page. And then when you go there, you can find a link to watch the archive. And then there is also a link that leads to a download option for our PJC starter kit, which is a PDF that's available for download that shows just basic tools and keys to success that we hope will be a way for everyone to be able to start a sustainable and innovative maternal fetal medicine focused journal club at your own respective institutions. Moving forward, our goal is that about twice a year, the editorial fellows will also choose an article to highlight for a live streamed journal club like we're having today. So for those, we will also prepare an article guide for you all to utilize in your in-person journal clubs or to join in on the larger conversations on the live stream like today.
Finally, before we kick off, just a few housekeeping items. So this journal club is being recorded and will be available for viewing after today's event. Regarding our agenda today, we will first provide a brief overview of the article and then show a pre-recorded interview with our senior author, Dr. David, who is also here with us today. And then we will hold a structured discussion about the article, which will also include our senior author. During the discussion, we would love for everyone to participate, and so please use the chat function on the live stream to post comments or questions throughout the session. We would like to hear from all of you.
And today we'll be discussing the article titled Prediction of Spontaneous Preterm Birth in Women with Previous Full Dilatation Cesarean Delivery. This research group is based out of the University London College in the UK. Before we hear from our author, we will briefly summarize the study. So this was a single-center prospective cohort study looking at cesarean delivery scar characteristics on transvaginal ultrasound in patients who had undergone a previous full dilation cesarean delivery and the risk of shortening cervical length and spontaneous preterm birth. In this cohort, the rate of preterm birth was lower on like 4.1%, and 12.8% of patients developed short cervical length. A low cesarean scar, which is within the cervix or less than 5 millimeter above the internal cervical os, significantly increased the risk of developing a short cervical length under 25 millimeters and or spontaneous preterm birth in a subsequent pregnancy.
Now let's watch a pre-recorded interview with Dr. David where she discusses the study group's motivation, study designs, key findings, and what they see as the impact of the work. Dr. Anna David is a professor in obstetrics and maternal fetal medicine and is the director of the Elizabeth Garrett Anderson Institute for Women's Health at University College London. She trained in medicine at St. Andrews University, as well as Manchester University, where she was awarded her Bachelor of Medicine and Bachelor of Surgery. She completed her OBGYN specialty training in London, in addition to a PhD in fetal gene therapy, and then undertook her MFM subspecialty training at University College London. She founded the Preterm Birth Clinical Service at University College London in 2008 and is the deputy director of the Tommy's National Center for Preterm Birth Research. She's an international leader in preterm birth research as well as prenatal therapy, and we are so lucky to have her join us today for our live stream. I was wondering if you could start off by telling me what inspired and motivated you to complete this study.
So I think I set up our preterm birth clinic at UCLH in 2008, and it was around about 2013-14 that I started seeing some women through our clinic that I wouldn't normally expect to see. So we normally see women who've had a spontaneous preterm birth before 34 weeks, and we screen, we do cervical length, and we follow them through. And I started seeing women who'd had a term birth in their first pregnancy, and then in their second pregnancy they'd had a really early preterm birth spontaneously, and I couldn't really understand what was going on. And it was around that time that we started realizing that if you ask the right question, which is how did you deliver your term baby, that then it started falling out that there was this issue potentially with late stage, and I say it's not just 10 centimeters cesarean sections, but it's 8 and 9 centimeters late stage cesarean sections, and potentially damage to the cervix. And then there was a landmark paper, I think, which was published by Levine in 2015, which was from the US, and it looked at the risk of preterm birth in your next pregnancy according to how many centimeters you were when you had your cesarean section in your first labor at term. And what she showed very clearly was there was a direct correlation between how many centimeters you were dilated and the risk. And so the risk was around about 13 to 14% if you had a previous 10 centimeter cesarean section. And of course, it went down a little bit lower. So even 8 or 9 centimeters are a slightly high risk. And I was starting to see women in my clinic who shouldn't have been there, according to me, you know, that had a term birth. And then we started imaging them. We always do a cervical length scan, and we started noticing that there was this gap in the cervix. And I spoke to my gynecology colleagues, and they said, well, Anna, that's the scar. And I went, what do you mean that's the scar? They said, that is the cesarean section scar. And of course, when you look in the gynae literature, there's a whole wealth of literature showing that women who have a cesarean section, if they have a late stage cesarean section, there's a bigger scar, there's a bigger niche, it's lower down near the cervix. And so it all came about really through that. And we started realizing that these women had a big problem if they'd had a term full dilatation cesarean and then a spontaneous preterm birth in their next pregnancy, because when we put in a stitch to try to prevent them going into labor again when they shorten their cervix, they didn't work that well. So we decided to do an observational study. We changed our protocol completely in the preterm birth clinic. We started seeing women routinely who'd had a full dilatation cesarean section. And it was a group of us in the UK who did that as part of the UK Preterm Birth Clinical Network. And there was a document published called Saving Babies' Lives Care Bundle 2. And we decided as a group to see women who'd had a full dilatation section because there was around about, you know, 13, 15% risk of preterm birth, which is probably similar to somebody who's had a spontaneous preterm birth vaginally in their first pregnancy. And at that point, we thought, well, hang on, we're seeing these big scars. What is the relationship between the scar and the risk of preterm birth? And that's really where it all kicked off. It came from a couple of patients. I was like, you've got a big scar in your cervix. What is that? And then we put in a stitch and we realized that that stopped them going into labor. So we started looking properly at the cervix with our ultrasound.
Would you be able to walk me through, how you interpret these images that you were getting in the clinic? I'm
Yeah,
gonna
absolutely delighted.
show
Yeah.
it right
Yeah.
now.
So the technique is really, really simple. It can be it's now I do it as part of any simple ultrasound that I do. So what you can see here is we've identified the internal os. And what we do, as I said, is we put in the transvaginal probe. You must make sure you've got a nice empty bladder, as you can see here. And you've got an equal amount of cervix of the anterior and the posterior cervical os. And you've got the canal, a line that you can see very clearly. And there is a scar. This black line here is what you see when you have a scar. Now, it hasn't really got a very big niche. The one on the other side has got a slightly bigger niche. A niche is defined as a gap or a defect of 2 millimeters or more. So this cesarean section scar on the left is above the level of the internal os. And this cesarean section scar on the right is below the level of the internal os. So you can see this one on the right is actually in the cervix. And what you find is when you scan these women, they don't really shorten their cervix, and they don't always shorten their cervix, but what tends to happen is around about 16, 18 weeks, the lower part, the isthmus, opens up, and this area of the niche is sort of tented up, it's tacked up into the scar, and so it almost starts opening up from there, and you get funneling. And so that's what we see is we see people every 2 weeks from about 16 weeks, we see them 16, 18, 20 weeks, we do the scan at their anomaly scan, and then we repeat the scan at around about 22 weeks. And generally, if it's going to happen, if they're going to shorten their cervix, it'll happen around about 18, 20 weeks. And then, of course, the decision is, what do you do about that when you've seen they've got a shortening cervix, which I'm sure we'll have a chat about.
Yeah. And then these were the second images that you included in your publication
Yeah.
regarding,
So
I think, the niche measurements.
Yeah, we wanted to do lots of measurements just to work out. It wasn't just the height of the scar. We wanted to work out, were there any other measurements that were going to be important in predicting potentially whether women developed a short cervix or went into labor preterm. So you can see here you've got the level of the internal os, the arrow is there, and then you've got the niche, and it's quite a big niche this patient has got. And you've got the niche length and the niche depth, and then you've got the adjacent myometrial thickness, so the whole thickness of the anterior myometrium adjacent to the scar, and then you've got the residual myometrial thickness, or the RMT, which is the amount of myometrium that is remaining just above the scar. And there's the anterior cervical lip at the top and the posterior cervical lip at the bottom. And then what we did was we rotated on that niche, and we got the view, transverse view, and measured the niche width. Now, the most important thing actually to realize is that these measurements take a little while to do, but the most important measurement that we had was in fact the shortest distance between the cesarean section scar and the internal os. The niche depth, the niche length, the RMT, AMT niche width were not particularly useful in predicting who was going to shorten their cervix and who was going to go into labor preterm.
You had briefly mentioned, it's important to figure out what do you do, what's the next step once you find these abnormal findings. And, in the United States, when we have a short cervical length in a woman with a singleton pregnancy with no prior preterm birth, we recommend progesterone at a cervical length less than 20 millimeters, and then also a cerclage we discuss at less than 10 millimeters. I was curious as to what the practice is in the United Kingdom.
Yeah, so I mean, in the UK, the practice is that if women shorten their cervix down to at least 25 millimeters, then we would tend to do something. So either we give progesterone or we put in a stitch. Now, generally, we offered women a progesterone, but we knew from previous data comparing risk of preterm birth in women who have a scar or have had a previous term cesarean section that a cerclage may not be as useful and progesterone may not be as useful. So we were sort of functioning really in a bit of an evidence vacuum. So we decided as a team that we were anybody who got down to a cervix of 25 millimeters or less, and basically that means they funneled their cervix. Generally what you find is the cervix is long, 16 weeks, and then suddenly 18 or 20 weeks, it opens up, it funnels. And often it funnels really quite a lot. So you're talking about cervical lengths that are around about 15 or even 10 millimeters. And we decided as a group that we would offer cervical cerclage, and we would offer progesterone. There was a randomized controlled trial that was happening at the time that we were recruiting to. It was called CRAFT, and it was led by Professor Andrew Shannon at St Thomas's. And the randomized controlled trial was trying to decide if women should have progesterone or cervical cerclage. And we were the only team that recruited to the trial, were able to recruit to the trial. We recruited 2 women, one who was randomized to progesterone and one who was randomized to cervical cerclage. But it was over COVID. It was really difficult to recruit to the trial. So really we were left in a bit of a vacuum. And so we decided that we would be offering cerclage to women who developed a short cervix. So just to give you a bit of an idea about what we found in the study, so around about 90% of women had a scar visualized. So that's 10% of women didn't have a scar visualized, and they were very unlikely to go into labor early. So that's a positive finding. We found, so that was a study of 243 women. We saw a scar in 220. And only 31 women developed a short cervix. So, most women don't develop a short cervix. We put a stitch in the majority of the women who had a short cervix, and our overall preterm birth rate was 4%, 4.1%. So a really low preterm birth rate. So we were quite reassured by that. But, we can't definitely say that the right thing to do if you identify a short cervix in a woman with a previous full dilatation section is that you put in a stitch. It could be that giving progesterone is sufficient. We just don't know. So we need to look at that really from a more multi-center type approach, because this is only a single center study.
Yeah, so were the patients given the choice of if they were going to get progesterone or the cerclage?
Yeah. So what we do, we gave them an option of progesterone. We always send off a urine culture, because we have experience where people can shorten their cervix simply because they've got a urinary tract infection. So we did a urine culture. And then we basically said, we don't know what is the right thing to do, but if you would, these are the risks of a stitch. If sometimes people said, I'll just stick with progesterone for a week, we'll see you in a week, and then if it shortened further, we'd put in a stitch. So a lot of people decided to go for a stitch. But what we found was ultimately the position of the scar was super important. So if the scar was within 5 millimeters above the cervix, above the top of the cervix, or if it was within the cervix, there was a much higher chance of them shortening their cervix, and a much higher chance of delivering preterm. And so I think that's the key thing, is that the position of the scar is really, really important. And that's what we learned from the study. I think that was the most interesting finding. The other abnormality, the other, markers like AMT and RMT, not particularly useful, but it's the position of the scar. So if you've got a low scar, there's a much higher chance of them shortening their cervix and delivering preterm. Yeah.
How has this changed either how you practice as an obstetrician and then also what you're doing on your ultrasound unit?
So in terms of how I practice, so I now tell everybody who has a full dilatation cesarean section, I mean, we now have a standard procedure in the hospital that everybody is informed that they have a slightly higher risk of preterm birth and they should have their cervix measured in their next pregnancy. I think the same should be said for 8 or 9 centimeters. So I've had another PhD student working on this project who's looked at scar presence and size according to the dilatation at 8 and 9 centimeters. And she's been looking postnatally as well, so at 3 to 6 months of age. And she's found you can see the scar. What we don't know is if the position of the scar after you've had your late stage cesarean section is the same as when you get pregnant next time. So we're following that through. But I think it certainly made me much more aware about if I'm doing a late stage cesarean section, that I try to make my cut as high up as possible. But then you've still got to be able to deliver the baby. You've still got to be able to get that head out. Yeah, it's just we're just much more aware of that risk and telling patients, because we know that if we tell them and they come through our clinic and we see them, we identify they've got a shortening cervix, we put in a stitch, actually their risk of preterm birth is really quite low.
Were there any limitations that you think readers should be aware of?
Well, of course, the major limitation was that we were not blind to the results, and we had already decided that we were going to do an intervention and we were going to choose to offer women a cervical cerclage. So it is not a randomized control trial. This is a real life sort of observational prospective study. So ultimately, what we should try to do is a randomized control trial. Of course, we tried to do that and it was actually very difficult to do. So maybe we need to think about doing a study which has units that only offer vaginal progesterone and units that offer cervical cerclage, and compare the outcomes with those 2 units. Because we tried to do an RCT and we couldn't get it done. So yeah, that is a major limitation, completely accept that. But this is real world research, and you just have to accept that that's what's going to happen.
All right. Well, thank you so much, Dr. David, for your work in preterm birth, to your team in this study, and for being a part of this project for us.
It's an absolute pleasure. I'm very happy and great to talk about this study because we really enjoyed doing it. Thank you.
Thank you, Dr. David, so much again for your insight into the study. Again, Dr. David is here with us live today. If you want to wave hi.
Hi, everybody. Good evening, wherever you are. Good day, wherever you are.
Thank you. And now let's go into a deeper dive regarding the study using the tools we recommended in our AJOG MFM Pink Journal Club Guide. Again, we'd love your participation. So any experience from your own institutions or questions for the author, Michelle will be screening through the chat and the questions to share your thoughts.
All right, so to begin, one question we had for everyone was about their routine practice. Do you all routinely evaluate scar location or niche features in patients with prior cesarean delivery in general, and those with specifically full dilation cesarean delivery? Have you incorporated scar assessment into your own practice? And if not, do you think this study justifies routine scar assessment for those with a full dilation cesarean delivery?
I was thinking about this and kind of doing a pseudo poll around my hospital. In our institution, I think generally in first trimester ultrasounds, scar location or niche features aren't necessarily routinely evaluated in all patients with a history of a prior C-section. I think if they've had multiple prior sections or a history of a dehiscence or uterine rupture, or obviously if there's features in real time that are suspicious for a cesarean scar pregnancy or a CREDA spectrum, then they might have a more in-depth interrogation of the scar or the niche by the sonographer or the MFM. And then the question about whether or not this would support changing routine practice, I think to begin, it's trying to figure out if these findings would be reproducible in different patient populations, maybe ones that are more similar to the ones at our respective institutions. And then if it's validated, sort of figuring out how to protocolize it and also validate to make sure that we can ensure quality. So I think thinking like any new sonographic skill that might be needed, thinking like NT size or first trimester anatomic evaluations, which are increasingly more common, I think we'll just sort of need some universal standards on how to assess this and then ensure quality of the assessments by our sonographers across our institutions.
Yeah, I mean, very interesting. I also agree. If the findings were like validated at more centers in broader patient populations, it definitely can be something to consider incorporating into clinical practice. I guess another thought I had was that, transvaginal ultrasound is really practical and accessible modality. It offers great anatomical assessment, looking at features like RMT or niche depth, but it doesn't necessarily capture like functional or biomechanical properties of scars or cervix, which can play a significant role in outcomes like preterm birth or uterine rupture. So factors like tissue elasticity or strength or scar remodeling can influence risk, but remain very difficult to quantify as of right now, with current standard imaging. But I think transvaginal ultrasound would be a great start for the time being.
Dr. David, what has your experience been at your institution regarding use of transvaginal ultrasound for scar assessments? Have there been any specific limitations, such as generalizability, operator variability? Have there been any practical buy-in and uptake issues by the sonographers, providers, and how do you feel it has been able to change patient counseling or provide provider practice? And then also, if anyone wants to chime in the comments, we're also looking at those as well.
So yeah, I think it's a really important question about standardization and making sure that what you're doing is reproducible. So before we even looked at the association between the cesarean section scar measurements and the risk of preterm birth or the risk of shortening cervix, we did a reproducibility study. So there were 7 of us in the preterm birth clinic, all trained MFM ultrasonographers. And we basically did an intra-observer variability and an inter-observer variability. So 7 of us, if we did intra, we would basically come in, scan the woman, and then another person who was in the clinic would also then scan the woman just immediately afterwards, blind. So we didn't think about where the scar was. We were just saying, can we see it? What are the measurements? And then somebody looked at that data. So we found that there was really, really good reproducibility. I'm not sure if I can put the anything in the chat about the paper, but the paper wasn't published in AJOG MFM. It was published in Ultrasound and Obstetrics and Gynecology. But it basically reproduced. We could show there was really good reproducibility for this measurement. So I think it's reproducible. Of course, you just have to go through the steps. And we've actually developed a training video now, which we validated the actual training video technique, because it's straightforward. Once you start doing it, once you start doing that scan and you start, you put the probe in, you move it very slowly to the side, you put on your color Doppler, you identify your uterine arteries as they go straight just down the side of the cervix. That's the top of the cervix, that's the internal os, and then you move it slightly over again. And you do that again. You start using this technique all the time, because very often at 12, 14 weeks, the isthmus will be basically closed. And so you might think that the cervix is a good length, but actually you're not measuring the top of the cervix. So we reproduce this technique. And I think it means that we are now using this in the clinic, and it's incredibly useful to do that. But we have to roll this out. We have to make people feel confident in their ability to see the scar. And it's interesting, we've done some training around the UK. I mean, as soon as you point out to people, that's the scar, they go, oh, golly, I thought that was just a blood vessel, or I wasn't sure what that was. I thought that was just shadowing from the pelvis, but actually that's the scar. So yeah. Hopefully I can put something in the chat about the URL for the reproducibility study. I'll see if I can do that here.
Sorry, I was muted. I think one other question that just came in through the chat was from Dr. Brigella. It would be great to hear from Dr. David about how to study the transvaginal cervical length when in non-pregnant patients with prior C-section at full dilatation. Can we tell if the scar is above or below the internal os while not pregnant?
Absolutely. That's those studies have already been done in non-pregnant cases, and in fact, there's a really good body of literature which has demonstrated that you can see the scar, you can measure the scar position reproducibly in women who are not pregnant. So we sort of we took the technique, we stole the technique from the gynecologists in some ways, and just validated it in the sort of pregnant rate, the pregnancy range that we were seeing between around about 14 and 22 weeks. It's really not difficult, and if you ask the gynecologists, they will often say, well, of course, we always see the scar, and increasingly they're seeing scar pregnancies, scar ectopics. And I think the more cesarean sections that we do, particularly in labour, particularly in women who have late stage sections or perhaps decline into instrumental delivery or something like that, we're going to see more and more of these cases. And there is a body of literature around scar problems outside pregnancy, particularly recurrent intermenstrual bleeding, and some surgeons are now operating on these niches, removing them, treating them, and having good outcomes. So I think we're going to be seeing much more of this.
Thank you. I think we'll go to our next question that we have for the group. Thinking about, so how might prophylactic interventions that we talked about that were also discussed in the interview, so cerclage or progesterone, have influenced the preterm birth rate overall and also just model performance? And how do we, use that to think about the findings in the study?
Yeah, and I think that's a very interesting question. And there's probably like two main considerations here. One is about the effect of the interventions on the observed preterm birth rate. And the second is the effect of the interventions on the model performance. Because we know both cerclage and progesterone can reduce the risk for spontaneous preterm birth. So the observed event rate really would be not reflective of the true baseline risk for the population. And some patients with high-risk features could be delivered that term because they were effectively treated. So that could mask the true strength of those predictors, making them appear less impactful than they actually are. And similarly, it impacts the model performance because the model could underestimate the predictive value of risk factors if the risk factors also triggered interventions that prevented the outcomes. Something of what we call like treatment confounding, where the predictor and the intervention are closely linked. And to address this, we can consider different approaches, maybe adjusted models or sensitivity analysis that would exclude treated patients or treat intervention status as a covariate, which would provide a better estimate of the natural history risk and improve the model validity and clinical utility. Otherwise, we can also consider doing stratified analysis, treated versus untreated, and see to clarify better how the predictors function differently across the groups.
I think another important consideration is whether the participant got a cerclage or if they got vaginal progesterone, because this was based on joint decision making between the provider and the patient. And so additional co-founders that may have affected the treatment decision could also affect the preterm birth rate and model performance. In addition, they use the criteria of a cervical length of less than 25 millimeters for both patients who had a prior preterm birth and those that did not, which is different than what we currently practice in the United States in regards to cervical length and who we offer these interventions to based on if they have or had not had a preterm birth history.
I guess, Dr. David, do you have any thoughts on, or did reviewers have any thoughts either when you submitted the paper about sort of what the influences are of these measures on the preterm birth rate overall and just the model performance?
Yeah, I mean, I think a lot of things probably play into it, not just the dilatation of the cervix. So I'm sure that there are things to do with how the scar has healed, which probably influences the size of the niche. So I think the size of the niche is probably quite important. As well, if they've had a cervical tear or a uterine tear. So in addition to their cesarean section scar, delivery. So I think that's going to be one of the issues that we are going to need to explore. And if you think about it, certainly at our institution, 50% of our women are having a cesarean section. Okay, many of them are elective, but of those that we do, a high proportion of them are our emergency in labor, how much do we actually know about how we do those cesarean sections, what techniques we use to influence the outcomes? Should we be doing locked and unlocked? Should we be doing double layer, single layer closure? We know that probably, we know a little bit of data about the risk of scar rupture and dehiscence in the next labor, but do we know that much about how they heal and the risk of preterm birth? I don't think we know enough, and so I think we're going to need to do a lot more research, collecting up really useful information like BMI, blood loss. Did they have a fever in labor? That kind of thing is really going to influence the scar healing, and that probably is going to influence what the consistency of the scar, the defect, the size of the defect. Are there bacteria in the niche? We really don't know about that. So that's really going to influence how we treat these women when we actually see the scar and when the cervix shortens. I've just put in something here. I put in one of the papers about cesarean section scar assessment for pregnancy that you can share with the viewers.
Perfect. And we popped Dr. Bergella back in the chat as well, since the bulk of your research and expertise is also around preventative measures like cervical length screening, cerclage placement, and progesterone use. So we didn't know if you also had thoughts on just sort of generally what the measures are, influence of these measures are on model performance when attempting to model preterm birth risk in papers such as this one.
I think, I think we need large numbers to know that. I think I suspect that progesterone's probably not going to help a lot if you've got a scar that's tented up and is incredibly short. So what we see is when it funnels, if the cervix is definitely if the scar is definitely in the cervix, it's sort of pulled open. Sometimes we find such that when we get to put in a cervical cerclage, that actually we have to put in a Shirodka. So that's because when we get them into theatre and we put in the anaesthetic, we put our sponge holders on the cervix and we pull it down and it's stuck. It's like it's almost stuck, scarred, and that's because the anterior lip is scarred. So we end up actually dissecting around and doing a Shirodka, getting on our stitch quite high. So I suspect that progesterone is probably not going to work as well, but I don't know, and I think we need to look at the data. So I wouldn't want to influence your listeners to say you definitely have to put in a stitch. You definitely only can you definitely not have to put in a stitch. I'm sitting on the fence like a good researcher.
Dr. Bergella, do you have any thoughts about this question?
Yeah, but lots of thoughts. First of all, actually, last night we had a lady who delivered 22 weeks, was transferred from somewhere else. She had 2-term births. She was 5 centimeters at 22 weeks there. By the time she was transferred, she became fully dilated with bulging membranes. And when we looked at her history last pregnancy, she delivered a term and had a C-section in the second trimester after pushing for a couple of hours. So exactly, this happens all the time. Another comment I have is, I think that cerclage in general has been helpful. I've been studying for a long time, like Dr. David, and it's interesting in different populations, as long as the cervix is short and weakened and whatever, it seems to work. 30 years ago, I didn't think so when we had a few patients, but I think eventually it'll be feasible to do a randomized studies. I'm more optimistic. I think it's really, really difficult. For example, we're doing a randomized study now, 24 to 36 weeks, short cervix, if cerclage works there, and it's painful, to randomize. But it's doable. And I think, like Dr. David said, even retrospective data at this point is helpful, controls versus cerclage versus progesterone. I think all of the data points to the fact that if the cervix is really short, that's when cerclage helps the most. And I think in this patients had the same clinical experience as Dr. David. They shorten quickly, sometimes even early, like a 14, 16, 18 weeks, and they shorten, less than 10. And I think the progesterone in patients like this that clearly have a mechanical issue, not an immune issue or, hormone issue, that cerclage is probably going to be more efficacious. So I'm really delighted you picked this article for your first journal club, and thank you. The last comment I want to make briefly is also Dr. David mentioned this prevention, at the C-section. Finding out, and you guys are the young ones who can do the studies, finding out how high, we should go to avoid being below the internal os, some landmarks at that fully dilated C-section. And again, the techniques, do you take the full thickness? Do you don't? What suture you use? There could be many things we're not even thinking about today to prevent, a large niche, and especially a niche that is too low. So it's much too, it's great data, and it just the more research to do, the more complex it becomes, and the more fun it becomes. So thank you, Dr. David, and for great research.
Thank you both so much for your insight on this. In fact, that was actually jumping into our third question, which was really about thinking beyond the paper, how we can change practice, thinking how this paper really changed practice at the time of ultrasound, and curious how the study could influence obstetrics and surgical decision-making at the time of second-stage cesarean delivery specifically.
I think about this in two different areas where this might impact practice, both in patients who are having a fully dilated C-section and are now pregnant again, as well as those who have undergone a cesarean section with fully dilated. So for patients who've had a prior pregnancy with a C-section where they were fully dilated and now they're pregnant, you may consider an indication to begin cervical length screening at 16 weeks gestation, even if they had never had a preterm birth before, because it is currently not a criteria that we're using. And it'll be interesting to look at for these patients who've had a fully dilated C-section but no prior preterm birth. Do we offer them a cerclage at 25 millimeters like they did in this study, or do we offer it when the cervical length is less than 10 millimeters, which is the current suggested practice for women with no prior preterm birth? And then the other area I think it would be interesting to think about is how this is going to impact your surgical approach. So Dr. Briella had mentioned a few different aspects that we should be thinking about, like closure technique and such. But it would be interesting to look at the same cohort to see if there was any differences in what the closures were like, such as what the sutures were used, if there was single or double layered closure. In addition, if there was any extension of the hysterotomy, especially inferiorly into the cervix or into the vaginal area. And if there are certain correlations between those things and subsequent risk for preterm birth, then this could certainly impact surgical approach at the time of fully dilation cesarean. What do you guys all think?
Yeah, I mean, absolutely. It's super interesting. I think generally whenever we think about second stage arrest cesareans, really thinking about like getting the C-section done and thinking about the patient and the baby, basically, but we think about increased surgical risk, for example, like hemorrhage, difficult extraction, needing a hand from below, considering reverse breech if the head's really wedged, and thinking about how thin the lower segment could be, and to mitigate various risks, like generally preparing to have uterine tonics in the room, having someone on standby to help with the hand from below or fetal pillow as needed, etc. But we don't typically think about doing anything specifically different at the time of surgery. And the study definitely made me and would make anybody really thinking more about modifications with cesarean technique in those specific cases of full dilation C-sections, and really thinking about what can we change intraoperatively.
Yeah, and I think a lot of those potential ideas have been kind of brought up both by Dr. David as well as Dr. Briella, but I think extrapolating from the findings from the study, if we think that a lower incision is associated with maybe an increased risk of a preterm birth, then would you maybe recommend making something somewhat higher within still the lower uterine segment, or maybe even thinking about like a primary low vertical or some other alternative way that might mitigate that very low scar risk? And then the same way that we might try to avoid having bleeding associated with an extension, we would also want to avoid an extension in this case for the sake of potentially preventing a preterm delivery. So not necessarily that you're maybe doing anything different, but just sort of having another, both short-term as well as long-term outcome to think about. And then I think some of the other things like locking or not locking, and then second layer or imbricating layers, or if there's any other strategies that might make any difference. And I don't know, it sounds like you've had a lot of, Dr. David, multiple sort of branching studies from this one as well. So I don't know if you guys have looked into this or have any preliminary thoughts on what you might think influences surgical closure, incision types, or anything like that.
Yeah, I mean, I think the first thing to think about is actually is a cesarean section birth the right thing to do in this particular patient? And I think, you know, rehabilitating straightforward instrumental birth as a really important, useful skill that may be the best option for a patient where the head is really low. So the follow-up study that one of my PhD students, Maria Ivan, has been doing suggests that actually factors like the station of the head at the cesarean section is super important, perhaps more important than the actual dilatation if it's 8, 9, 10 centimeters. And things like the estimated blood loss, if the baby is bigger, of course, and there are lots of other factors, and those are things that go into the healing. So I've certainly had a couple of patients who have chosen to have a cesarean section when they've been given the option of an instrumental birth, maybe a forceps, and they've said, I don't want to have a forceps. So clearly the baby was low enough for them to be delivered. And then in the next pregnancy, we're seeing them and they shorten their cervix. Fortunately, we've caught it. We've put in a prophylactic stitch, and whether it works or not, you know, these were women who had a short cervix of sort of 10, 15 millimeters. They've had a term birth, which is great. But I think we need to rehabilitate our vaginal birth skills to say these are really important things. And it's not just damage to the baby that we might need to be counselling about with a forceps. We might be saying, actually, if we do this, we are less likely to damage you and less likely to cause you to have trauma that might affect your next birth. I think the other things to think about are, very, very important. Should we be thinking much more about reverse extraction? If you go too high, then you get your hand in and you can't get the head out, and then you're going to create a tear. But then, of course, if you go too high, you might have a higher risk of placenta, accreta, and all these kind of things. So there's lots of research that you guys need to do in the future, thinking about what are the techniques that we can really bring to bear. I think the last thing to say is, who should we be offering transabdominal cervical cerclage to? So that's one of the areas we're seeing increasing numbers of women who've had a full dilatation section. The next pregnancy, they've had a baby loss because they've not been screened, or perhaps they have shortened their cervix, they've had a stitch and it's failed. And I see them and I'm like, and they say, well, why did I go into labor early? What's the problem? And you see a scar. In that situation, I am now referring for a laparoscopic pre-pregnancy transabdominal cervical cerclage because they've had a failed stitch. But, you know, there is a research study ongoing at the moment above, which is run by Andy Shannon's team from St. Thomas's. We're taking part about what is the right stitch to do in this situation where you've had a labor cesarean section, you've had a preterm birth, subsequently, what do we do? And so I think we need to do a lot more thinking about what's the right thing to do in these women. And we're really keen to make sure that the scar is measured as part of that study, because it could be that actually if you have a high scar, you're fine. If you have a low scar, you need to have a tack rather than a vaginal cerclage. So lots to do. And I'm really very happy that you chose this study to stimulate, hopefully, the discussion that will happen in labour wards around the world now.
Yeah, I think this article is going to make us think a lot about what we're doing on the labor unit and in our ultrasound unit, as well as like what else do we need to still figure out and do research on. My final question for you, Dr. David, is what future studies would you design to validate or expand upon this work? And for those who are unsure about the study and would necessarily change their practice, what do you think future studies would need to do in order to adopt this approach? And lastly, what are maybe some opportunities to collaborate with American researchers to further, understand this and look into this?
So I think that there's a big body of data now showing all around the world that a full dilatation section increases the risk of preterm birth. What we need to do is reproduce the research that we've done, which shows that the scar position is important. I think so that would be great to reproduce it. In fact, we're going ahead with a study in the UK. We're using the UK Preterm Birth Clinical Network, where we have a number of big centres who are also seeing women in the preterm birth clinic with this risk factor, measuring the scar independently, and so we can bring this together as a prospective, observational, multi-centre study. So that's the first thing: is the scar position and the niche as important as what we found in our single study. I think that the next question is, okay, if you have a low scar and that's associated with an increased risk, what's the best treatment? Potentially, we might be able to randomize women. I'm not against having another go at a randomized control trial. And that should probably be multi-center, potentially with centers in the US and other countries where they're now seeing this effect. And I think that's important. The other thing with any prospective data going forward is we need to collect up all the other information about what happened in their labor. So were they induced? Did they get oxytocin? What was the estimated blood loss? Which way around was the baby? Was the station +1 when they had their section? Was it -2? Was the baby OPOT? How much did they bleed? Were they older? It's one of the potential risk factors. All of these risk factors about healing, and then to translate and link that up with the risk of preterm birth. So yeah, lots to do. Really happy to have conversations with people about what we might go with and how to actually do the scar assessment. As I said, we've got a video that we've developed. We've validated the training tool, and we're hoping to get that out and published and share that with people around the world to get people looking at the scar.
I think just as a follow-up to that, we got a question also. Is that video currently available to see for other people, or is that something that's a work in progress, not yet live yet?
So it is live. It has been commented on. We're hoping to submit it for publication, so I'm not sure that we should share it at this point.
Okay.
Because that might compromise any exception by a journal. I'm not putting Vincenzo Professor Vergello on the spot here, but yeah, we'd like to get the video out because it's done with animation. We've got examples there about how to do it. But yeah, so the plan is it's been funded by Tommy's charity, great, and we had patient input into the design. And so we really want to get that video out as soon as possible. So we're working on the patient and on the paper, and it will be submitted very soon. And as soon as it's out, we'll share it.
Perfect. All right. I think we're just about hitting the endpoint for today. So thank you everyone for joining us at our first ever AJOG MFM PJC. We hope that this session and conversation has been super insightful. I certainly know it has been for me, and that you all will continue to hold journal clubs within your own institutions using the guides that we create. Before we conclude the session, I just wanted to acknowledge a few people, including our AJOG MFM editorial mentors, and also obviously Dr. David for joining our live stream today, which has been so helpful to enrich that conversation about our article. And we wanted to thank Dr. Vergello for his support and assistance in developing our PJC and obviously training us in the technicalities of using StreamYard. And then also our faculty advisor, Dr. Adam Lukowitz, who has been instrumental in helping us develop this journal club series. We hope everyone has a wonderful rest of your day, and please share the YouTube link for anyone who wasn't able to catch it live. And thank you so much for joining.
Thank you very much. It was a pleasure to join you. I'd just like to acknowledge my team at UCL, who've just been fantastic. 2 PhD students, Maria Ivan and Rita Banerjee, my colleague, Raf Napolitano, Kasia Maxime, Davida Casagrande, Amos Tete. I mean, it's a huge team that's worked on this. And so it's a team approach. Team science is the way to go. And thank you very much for a fantastic opportunity to share it with you. And good luck, PJC.
Thank you.
Bye-bye.
Thanks, everyone.